is a video of a 67-year-old gentleman with severe waterworks issues who'd failed medical therapy and had a very large prostate. He underwent a laser enucleation procedure, or HoLEP. Here we are, we can see a cystoscopy being performed. The very large lateral lobes and the middle lobe are seen, obstructing the bladder. The bladder can be seen here with thick-walled or ridges known as trabeculations. These are appearances consistent with a bladder that's been working very hard for a long time to push the urine out through the prostate. Here we are mapping within the prostate the pathway that will laser to scoop out the adenoma or obstructing prostate tissue en bloc, that is as one piece, and leaving the residual tissue or capsule of the prostate intact. The best entry point here is posteriorly, which is where we're incising now. And it's the safest point to avoid damage to the urethral sphincter. We can see now the prostate adenoma or obstructing tissue is above us and the capsule is below us. The easiest way to think of a HoLEP is it's like peeling an orange from the inside out. We basically circumscribe the fleshy part of the orange and peel it, leaving behind the whole capsule or peel of the orange and dropping a single ball or the fleshy part of the orange into the bladder, where we will later morcellate the tissue and analyse for prostate cancer. Here we are, slowly peeling and carefully peeling the prostate adenoma off the urethral sphincter. I'll perform this very early on in the surgery to minimise traction on the urethral sphincter, which minimises patients' chance at having stress urinary incontinence. The risk of that is about 0.5%. Now continue the incision on the top of the prostate, or the anterior area, which is what's happening here. Above us on the top of the screen is now the capsule, and below us is the adenoma or obstructing prostate tissue. It is a bloodless, effectively bloodless operation. Patients will lose maybe 30 mils. They rarely come back to hospital with blood clots, and I'm yet to have anyone go back to theatre for a bladder washout. Here we are about to enter into the bladder. We can see the radial fibres being cut through. The incision is extended here on the left, and then it will be extended on the right of screen, which is actually the patient's left. So we're now cutting at around about 3 o'clock. So we've done the roof of the prostate. We've now done around to 3, so between 3 and 9 on the roof. And we'll continue this incision here around to join up with the posterior plane that we've already created. So we're now following around from 3 o'clock, back around as we go down here to 6 o'clock, and then up the other side to 9 o'clock. You can see the capsular fibres, which are the thin, white, wispy tissue areas. This is the peel of the prostate. And we can see the solid adenoma or obstructing prostate tissue. On this particular part of the video, we're now over on the patient's right-hand side, where the capsular fibres can be seen to the left of screen and the adenoma to the right of screen. We'll now join up with our previous incision. And we'll continue excising the adenoma until we get to it almost completely excised and about to drop into the bladder. With such a big ball of adenoma, it can be quite rubbery, and what I'm doing here is incising the prostate tissue to allow the morcellator to have better grip. Here's the final cut at the bladder neck. We've now completely circumscribed the adenoma, and we'll be able to see it in the distance in a second with the prostate capsule in the foreground. At this point, we're still in the prostate capsule, just drying up the small amount of bleeding that's occurring. We're checking that there's no damage to the important ureteric orifice, which connect our kidneys to our bladder. We can see the ball of adenoma here in the background. And now the morcellator is placed into the bladder. It's essentially a specialised vacuum with teeth, which allows us to analyse all the prostate tissue that's been excised, make sure there's no prostate cancer, and clear the tissue out to allow the man to pee. This gentleman went home the following day, catheter free and voiding freely.